Mark.
Yes.
It's Charles Nicole Hospital. That's
yes.
right.
Yes.
Rouen. Rouen.
Yes.
The name of your city is Rouen. That's right.
Rouen.
Rouen. Okay.
Rouen.
Thank you. Thank you. Rouen. So once it's it. Vidrov Eye Microsurgery Institution, Moscow, Russia. Russian Federation. Okay, I think we can start now. That's right. Well,
Go ahead.
Okay, I think we can start now. Okay. So, good evening, everybody. We are starting this webinar sponsored by Novartis, and this webinar is a little bit different than other webinars. And as you all know, the webinars include presentations, and sometimes they are boring, but it is totally different this time. It's a panel discussion, no presentations, just group of videos and eminent surgeons with us. We have 4 eminent surgeons from different parts of the world. It's my honor to be with them. I'm going to introduce every one of them now, just after showing the idea of the webinar. Simply, we are going to show videos for cases of cataract, or maybe combined cataract and cornea problems. And while the surgeon is doing his surgery, he faces a certain problem. How can we deal with this problem? So it's a simple idea. We can face it as ophthalmic surgeons every day. And the aim of this webinar, not to show the difficult cases, the showy cases, no, just to send a message for the average surgeon how to deal with complications or difficult situations during cataract surgery. Honestly, it's my honor and pleasure to join 4 eminent surgeons from Egypt, France, and Russia, starting alphabetically. I introduce Dr. Hatem Ammar, professor and head of ophthalmology department, Sohag University. Hatem is my friend since a long time, and we had a lot of webinars together. He's known by his charisma of giving the nice videos and showing the difficulties with his nice videos. And definitely we're going to see nice cases today from him. And of course, we have also today Professor Boris MAlugen, who is a well-known scientist all over the world with his Mulligan ring, and which had made a revolution in the pupillary dilatation. Professor MAlugen is the head of the Vidrov Institute in the Russian Federation, Moscow. It's our honor to join us, Boris. And from France, we have Marc Maurine, professor and head of ophthalmology department in France, and he is just 1 second. I'm sorry.
Charles Nicole.
Yes, Charles Nicole University is the head of the ophthalmology at Charles Nicole University in Moron. That's right. The pronunciation is right.
Yes.
And really, I enjoyed being with Mark in other webinars. I was very impressed with his high skill in cataract and cornea, and with his innovations and the new ideas. That's why I asked him to join us in this webinar. And lastly, but not leastly, my dear friend, Dr. Mohamed Mahdy from Al-Azhar University, is a professor of Ophthalmology in Al-Azhar University. Again, it's my honor and pleasure to be with all of you. And we will now start the webinar. So let me share my screen. And this webinar is sponsored by Novartis, and I'd like to thank Novartis for give us the opportunity to show our colleagues and young ophthalmologists something new. And also I would like to thank R&M, of course, for their audiovisual help in this webinar. The webinar will be recorded on Zoom, and at the end we can send you the links to the WhatsApp groups, and I think it will benefit many of our colleagues and young surgeons. So this is the introduction of the panelists. I will be the moderator, and Dr. Hatem, Boris, Marc, and Mohamed will be my dear panelists during this webinar. So for the sake of time, let's start the first case. This is a straightforward case of phacoemulsification with the, of course, it is fastened twice or 3 times, doing the regular capsulorhexis, nothing new. With the Satu technique, have different techniques to do the capsulorhexis. Of course, having the iris spatula in your other hand works as a second hand that helps the not touching the conjunctiva. Doing the straightforward phaco with your custom technique, whether the stop and shop or the divide and conquer, it's straightforward, nothing. The visco on the cornea will help visualization of the contents of the eye, then removal of the epinucleus, and that's it, no problem at all. And at the end, after finishing the irrigation and aspiration, of course, as you noticed, I'm putting visco before getting the phaco-tip out to keep the pressure of the eye, keep the eye pressurized all of the time. Cleaning the posterior capsule, putting your intraocular lens, and putting the intraocular lens under the irrigating solution. Nothing unusual, but once I inserted the lens, I found that the IOL is decentered like this. So it's a last minute complication. You finished everything. You have this picture at the end, dislocated IOL, zonular dehiscence, and there is no vitreous in the anterior chamber. What's your opinion, panelists? So can we hear Dr. Hatem, what's your opinion in a case like this? What you're going to do?
At first, I'll take a deep breath and start to evaluate, is there vitreous or not?
There is no vitreous.
No vitreous, I will start to inject this OVD, disperse OVD, to push the anterior vitreous face backward, then evaluate amount of dialysis. Here, I find dialysis is large, about more than 120 degrees. I think I will shift to insert Sione ring with suture, with 9-O-proline suture through the eyelets of the Sione ring.
And you leave the IOL inside, as it is?
No, IOL is inside the bag. It is inside the bag. I inflate the bag at first, and this sure every step will be re-evaluated. Sometimes in case like this, it can be turned up to remove the whole bag with the IOL and the blunt very size or something. But I feel in this condition, as long as the operation was so smooth, maybe but it will need suture. I don't trust to put CTR only in this condition.
Boris, what's your opinion? Boris?
It looks like the IOL is in the bag. And the reason for the zonal dehiscence may be a too excessive movement of the IOL when it was implanted. So I will probably start with the regular CTR. And as soon as the CTR will be inside the capsular bag, then I will decide whether or not it will be necessary to go any further steps. Because if it's not, so I will probably not go with the Sione from the very beginning. So I will consider that doing at the second step by implanting Ahmed capsular tension segment.
Yes. Okay. So this is the situation. I injected the viscoelastic, trying to reposition the intraocular lens in its place, but I found that there is something hindering. It is part of the capsule. So I decided, I found there is no vitreous inside, and I decided to insert a capsular tension ring. So you have to keep in mind that you have to have all your tools every time in your OR. You have to have a capsular tension ring, which is now mandatory for any subluxation at any time of surgery. And just inserting the ring inside the bag corrected everything. There is no vitreous, irrigation, aspiration, and removal of the visco approved. There is nothing. I didn't inject trimethylone. The patient was diabetic, and I injected him intravitreal Lucentis. So simply, a case like this was a simple maneuver. Let's see the second case of Dr. Hatem. Hatem, can you tell us about your case?
It's a smooth case with capsulorhexis. It is a little bit hard, but it is everyday practice in Upper Egypt. Dispersive OVD, removal of the nucleus. Everything is very smooth. Also a little bit hard, as UEFX is high the number. Irrigation, aspiration, cleaning of the cortex. OVD injection. Then, with insertion of the IOL, you are nearly finished. I surprised about this occurring. There is one haptic of the IOL inside the bag. There is zonular dialysis, as you see, subincisional in this area. Next slide, please. It summarizes the condition. One haptic inside the bag. There is rolled edge of the bag. One haptic, the trailing haptic is outside the bag, and there is zonular dialysis. Now the IOL is trapped, part inside, part outside, with zonular dialysis. What will you do?
Mark, what's your opinion? If you have faced this situation, what's your plan? What are you going to do?
Unmute, Mark. Mark, unmute your microphone. Yes.
Thank you.
What is important in this case is to evaluate the quality of the zonula in the other part of the dialysis. If we are sure that the zonula is perfect, we can use a CTR, of course, but I am not sure that the zonula is okay in the other part of the dialysis. So can you tell me how is the zonula in the other part?
All over the operation, the zonule was perfect. It is just occurred during insertion of the IOL. By repeating my video, I suspect that a little bit shallow anterior chamber, viscoelastic less than expected, so maybe mechanical. I find it, but intraoperative also hard, but was normal. Everything was normal.
So if we are sure that 3/4 of the zonula is okay, it's not a Marfan syndrome or something that. Yeah. So I will use a CTR in this situation to obtain a complete bag and then reposition the anterior lens.
Okay, Dr. Mohamed Mahdy, you have other opinion than just putting the CTR or getting the lens out, putting Versailles? What's your opinion, Dr. Mohamed?
Yeah, for this case, I suspect that zonular dehiscence occurred because it was already predisposed to that, because it is away from the proper way of insertion of the IOL. So it is not a mechanical. If it is mechanical, it should have been happened from the site of the entry. And even if it is shallow anterior chamber with little viscoelastic.
It is subincisional.
Yeah.
Dialysis is subincisional, Dr. Mohamed.
Just to stress on one point, Dr. Mohamed.
Okay. But here we have to reopen the bag, and we can insert the capsular tension ring from the right side here, and it could manage the case after inflating the bag, then inserting the non-inserted haptic inside the bag.
It is easy to insert the CTR while one bag inside and one haptic inside and one outside.
You would inflate the bag from the right side hand, and you put it behind the IOL, if you can do so. You can inflate the bag with viscoelastic first, so you will be able to put the capsule tension ring. or you could pull the other haptic out, but I'm afraid that you could more disinsert more of the zonules. You get more interrupts.
Dr. Mohamed, you said a very important point. I don't know if you can stress on it or not. Because these two cases, my case, the zonular dehiscence was while I'm inserting the IOL, it is at the opposite side of the wound exactly, okay? And Hatem case here, the zonular dehiscence is up. So you think—
Sorry, it is temporal. I am setting temporal routine. It is sub-incisional, yes.
Continue my message. Do you think if there is an iatrogenic induction of zonular dehiscence, it will start first at 6 o'clock because the surgeon pushed the IOL more than the usual?
No.
This may be a cause. And you mean that the dehiscence here, sub-incisional, is not related to the mechanics of entering the IOL? I want just to listen this point. Is there a difference or not?
Yeah, in Dr. Hatem case, there's a possibility because I was confused about it. It is directly under the wound, so it is possible to be a mechanical one. But in your case, I'm not sure. It might be a predisposed case. So in Hatem case, he could only insert capsule tension ring. But in your case, the proper way is to fix with Siuni ring because I'm suspecting that the other zonules is not intact.
Okay, so let's see what Dr. Hatem did. Dr. Hatem,
I decided to externalize the leading haptic from the bag at first to make the IOL in the anterior chamber, then inflate the bag. I was afraid if I inserted CTR while one haptic in and one out, it made the bag dislocated completely.
This is the bag. This is the edge of the bag.
This is edge. I will inflate this cohesive OVD behind the IOL in the bag to inflate it and insert the CTR underneath the IOL. The IOL now is completely in the anterior chamber. So it is stable in place in the safe side and will insert the CTR in this condition. As long as okay.
Your insertion of the CTR is intended in this way. So you are starting with the good part of the zonules to insert it and then back, or you can put it in the other way here.
No, I usually I insert it to the good area to avoid stress on the directed area.
This is an important message to the surgeons that you insert it through the good zonules, and then by its rotation it will come to the weak area. Further, Dr. Hatem.
Now you can reposition the IOL in the bag simply without need to exchange it. The same IOL, and the case, as if you move it more, it can finish easily, safely with irrigation aspiration. And you'll see well-centered, you'll see post-operative at the end. Irrigation aspiration, cleaning the OVD, everything is smooth. So the key is to find the problem early and avoid complicating it. Always pressurize the anterior chamber. In every case like this, never allow the anterior chamber to be collapsed. Even hydration of the wound while irrigation is continuous. So the eyeball always pressurize it to avoid any stress on the zonules. 1 week post-operative, as you see here, pupil is round, reactive, everything is okay.
Perfect. Very nice case, Dr. Hatem. Thank you so much.
Thank you.
For getting into Marc's cases, which are very interesting, just the message from the first 2 cases for the audience: please be aware of complications anytime, even at the last minute of the surgery. Be aware and be ready. You have to have your CTR, and once you are aware with the problem, wait. Don't run away, as Hatem said. Wait and reassess the situation. What is the problem? What happened? This will not, we are human beings, we will not have the solution immediately like here after studying the case. But once you face it, you have to wait, think what was the problem, analyze the situation, what happened, what's the situation of the capsule, are the zonules okay or not, and then you can manage accordingly. So wait till the end, be patient, give the patient his optimum chance to have perfect surgery. Be ready with your weapons, and assess the situation before doing anything till the patient and safely.
In addition to enough amount of viscoelastic, you know?
Yes, the visco is very important
Yeah,
because
this
once
what
the problem
happened.
happens, injection of visco, visualize everything, clarify everything, will make you understand what happened. And now we will move to this nice case of Professor Marc Maurine. And please, Marc, go ahead and tell us about your cases.
This is to present you the case of two patients in difficult situations because both have a cataract, but they have also corneal opacity secondary to Stevens-Johnson syndrome in one case on your left, and aniridic keratopathy on your right. And both patients have a decrease in visual acuity since 2 or 3 years secondary to this cataract. And there is a contraindication in both patients to lamellar or penetrating keratopathy because it is a lamellary stem cells deficiency. So we have to perform a cataract in such a difficult situation. So how do you do that?
So panelists, can you give us your opinion in a case like this, what we are doing in, in Egypt at least, we know that many patients with trachoma, they have advanced corneal scarring, and many patients, they cannot afford for keratoplasty, and others have limbal stem cell deficiency with the rheumatoid and the chemical burns. So we are facing cases like this. If it's my case, I'm just putting a lot of viscoelastic over the cornea, every few seconds even. I'm using more than 2 or 3 viscoelastics to be put on the cornea. Of course, dispersive viscoelastic polymethyl methyl cellulose, and this helps the visualization of the cornea, but definitely it's a hard surgery. It takes a long time. Dr. Hatem, Dr. Mohamed, Boris, what's your opinion in cases like this?
I think one of the issues here is to have a clear visualization through the cornea, and there are 2 different cases to the right and to the left. To the left, I see that the cornea in some part is quite transparent. So in this area, I will be able to visualize. However, in the patient with aniridic keratopathy, obviously the cornea is very opaque, and I will have been having issues with visualization. In that case, trypan blue and staining the capsule is very, very helpful in order to get the complete capsulorhexis. There are also some suggestions of performing side illumination. So when you take the endoscopy or vitrectomy probe, attach it to the limbal area and illuminate through the cornea, and you will be able to see how to go on with the capsulorhexis. So these are a little bit of tips that can help you to create a nice capsulotomy. In some cases, when the superficial cornea is, the surface of the cornea is not good, I used to remove the epithelium, and I used to remove like in the right case with aniridic keratopathy. So removal of epithelium and the fibrotic tissue, subepithelial tissue, will improve visualization. So these are some tips I will recommend in that case.
For me, yes, Dr. Ahmed, I think the first thing to me is to better patient counseling about the problems and the risks, the first thing, and much more better to have a high risk consent in this condition. Using OVD on the cornea, dispersive OVD to coat the cornea, trypan blue is very important. Sometimes I get benefit of the slit lamp attached to microscope. I have special type of microscope, which molar one includes slit lamp. Sometimes slit lamp with tilting the eyeball in different directions, you can see, although it's great difficult, but it facilitates things a little bit. But it is a really tough case.
Yes, and Dr. Mohamed Mahdy, I think you have also your opinion, because your opinion will go with one of the questions that are coming from the audience. You like the Sykes procedure. Mohammed, can you unmute yourself,
Yeah,
please?
I think I have met with some cases like this, but it was not as tough as this for sure. I could start doing the incision exactly at the area of this more not clear cornea, and I will maintain this area with little bit clear cornea to manipulate the lens material down to it during the phacoemulsification. But I will use I can clear the cornea by removing the epithelium and putting enough viscoelastic. Then I will use more staining from the trypan blue to make the anterior capsule more visible than I'm usually using in the other cases, and keep emulsification to the area of down and to the right. So I could have enough chance to see the lens material during the phacoemulsification.
Okay, let's see what Mark did. Mark, please go ahead.
Okay, I think all your advices are very good. Some of you spoke about the slit lamp, so we can use the slit lamp fixed to the microscope and we can see the cataract better. But my advice is to put in place a chandelier retroillumination at the pars plana. So this will improve the retroillumination, which is very important. So you put in place also OVD on the top of the cornea to regularize the deformation of the cornea. This is injection of trypan blue. And then you switch the light of the microscope off. And immediately you will have a very good retroillumination using your chandelier. And it is a very important point. And I wanted to show you the whole surgery using a retroillumination chandelier that you can ask to your retinal surgeon. Everybody has a vitreous cutter in your operating room, and you can add this. It's really easy. It's not really expensive. So this is the phacoemulsification as usually. I will not remove every time the epithelium. It depends on the pathology. If it's Stevens-Johnson syndrome, I will not remove the epithelium because the risk is to enhance the neovascularization at the end of the surgery in the post-operative period. So I will not touch the epithelium in this case. But there are cases, of course, where you will remove the epithelium and enhance the visualization. So this is the implantation of the intraocular lens. But if you perform this surgery on the aniridic patient, you have to be sure that the intraocular lens is absolutely in the bag. Because if you are not in the bag, the intraocular lens will touch the cornea. So this is the patient with aniridic keratopathy. This is using slit lamp, but you don't have a very good visualization. And this is with the retroillumination, with the chandelier, where you can perform the capsulorhexis. This is the phacoemulsification. So you have to switch the light of the microscope off to have the best retroillumination. And then you can see all the pieces of the nucleus. And this is the implantation of the intraocular lens. And you see using the slit lamp is not really good. But I used to perform endoscopy in my operating room. And you can control the positioning of the intraocular lens, and you see that the haptic is outside the bag in this situation. So you will try to reposition the intraocular lens till you will control the position of the intraocular lens into the bag. You see the haptic in the bag here, and in this patient without iris. So it's a good advice if you can have an endoscopy in your operating room to control the position of the intraocular lens. So retroillumination, slit lamps, OVD, trypan blue, and also endoscopy at the end to control. Thank you.
Perfect. Thank you so much.
You have a
Really,
question
thank
for
you,
Marc?
Mark. It's a great case, and the simple idea, just simply the chandelier illumination, which is available in every operating room, of course, because you have vitrectomy machine ready for anything. Even if you are not posterior segment surgeon, definitely if you are high volume surgeon, you have to have vitrectomy machine. So simply inserting the chandelier solved the big problem. But my question, I know that you, Hatem, you want to ask something, but I'm going to ask Mark a question before your
For the second
do you think this chandelier also will work with mature cataract or with hard or brown cataracts, Mark?
Yes.
Like it wasn't so dense cataract, this one. If you have a hard cataract, brown or mature, this retro illumination will help, will visualize the nucleus also in the same way, or it will be more difficult?
No, it's a good question. If you cannot have the retroillumination because you have a dark cataract, you will not use the retroillumination. So it depends on the opacity of the cornea. It depends on the hardness of the cataract. And I haven't shown you that here, but we are able to perform a cataract under endoscopic visualization, but it's very, very difficult. You have to train to do this kind of surgery. And this is when you don't have the retroillumination and a very opaque cornea.
Thank you. Dr. Mahdy, you had a question?
Yeah, I think for the first case, it was a wise decision to choose the chandelier system for doing the case. But for the second case, even after this enormous effort that has been spent to make a good phaco IOL insertion, the clarity of the cornea is not enough to allow this patient to see well. So the best technique for this is to do a triple procedure.
Is to do
a triple penetrating keratoplasty and phaco and IOL, because the cornea is not clear enough even after this maximal effort that you spent for.
No, this is a patient with aniridic keratopathy. This is a contraindication to penetrating or lamellar keratoplasty because it's an epithelium problem and it will recur after the penetrating keratoplasty or the lamellar keratoplasty. So this patient was only 0.05 after surgery, but was very, very satisfied. It's patient with nystagmus, it's patient with bilateral amblyopia, it's patient with many, many problems with aniridae. And it is difficult my advice is not to perform a trephination of the cornea in such patients.
Maybe
there are a lot of questions from the audience asking, as Dr. Mohammed said, why not to do combined? Why do you bother yourself of doing, don't do keratoprothesis? But again, the message here, if you cannot do keratoplasty for whether economical reason or for scientific reason, this is Steven Johnson syndrome. And as Mark said, the aniridic keratopathy, both of them will definitely will be rejected after the surgery. So there is no way of doing PKP, but maybe the question of keratoprothesis is an acceptable question also. Why not to do keratoprothesis? But of course, all of you know how keratoprothesis is difficult and how it takes a long time and the rejection and so on. And the other point that I know Mark wants to say also, that these patients are living with these corneas for a long period of time before getting the cataract. So they are adapted with this vision and they are satisfied with their vision with this cornea. So when the cataract added a burden for their vision. So if you can have a way to just remove the cataract, leaving the cornea the same, you will find these patients maybe or could be satisfied. What's your opinion, Mark? Are you with me that these patients are satisfied after this surgery in spite of this opaque cornea?
Thank you, Hamed. It's a very, very important remark. I have shown you two patients with epithelial problem, but there are also patients with stromal scar for 40 years, secondary to trachoma, secondary to infectious disease, and they lived all their life during 50 years with this cornea. And it's not always my advice to change the cornea when they are 70 years old, because if you can recover 0.3 or 0.4 as during their entire life, it's sometimes very, very good. And if your keratoplasty fails, you will have only contour finger at the end. So if you can remove the cataract in this patient, in this old patient with very ancient corneal problem, my advice is first to remove the cataract and to use some techniques to do that.
Thank you, Mark. Again, more and more questions about the limbal transplant. We do respect and agree. And
yes. We could do limbal transplant in the aniridic patient, but on the patient with Stevens-Johnson syndrome, nothing works.
Yeah.
Thank you. So we have to move to the next challenging case. Simply, this patient was a fungal keratitis and had a corneal scar and had cataract. So I decided to do penetrating keratoplasty after 6 months of subsidence of the infection. As you see, there is a lot of bleeding at the edge of the cornea, and the cornea is so thick and scarred. And then after we removed the corneal scar, ready for doing the cataract surgery, because I know there is a cataract behind, and freeing the angle tissue with viscoelastic, and then I found that the pupil is constricted, and this is the situation. So the question to the panelists: what are you going to do for this situation with constricted pupil? Boris MAlugen, can we hear your opinion of how to deal with this constricted pupil in an open sky keratoplasty? Do you think that your ring will work in a case like this without pressure in the eye, or you have another idea? Or do you think that we can put iris hooks without support at the angle? What do you think, Boris?
Dear Ahmed, I think there are several options in that case. We know that there are several temporary keratoprostheses that helps to remove cataract surgery in the open sky surgery, and also to perform vitrectomy. So this could be one option. However, in that case, I will be definitely using the Mulligan ring. And the reason of that is the recent publication by the British colleagues who showed us that using the bigger ring, like 7 millimeter, in that case, not only helps you to expand the pupil, but also helps you to keep the iridolenticular diaphragm, because the corners of the device goes into the anterior chamber angle, and the whole diaphragm is not lifting upward. So this is one of the possibilities, not only to expand the pupil, but also to keep the situation under control, is to use the ring. There are several other options that you may think, is that to perform sphincterotomy, or expand or try to tear the pupil and expand it a little bit. It's not very useful to use hooks in that case, because it's not so easy to keep them in the eye. So there are several options that may help you to deal with that. However, this is all of course, a very challenging case.
Okay. Any comment from Hatem?
I think this case was very narrow pupil. You will need to use more than one maneuver. I think we will, if there is a membrane, we will remove it and do microsphincterotomy, then implant Mulligan ring. Mulligan here is of a great help, but I feel if you use the larger sized one, it'd be more helpful. 7 millimeter, not 6.25.
Okay, Dr. Mahdy, do you have another opinion?
Yeah, I think I did work with some cases like this. It was pseudo-exfoliation cataract, but I think as long as you have an open sky like this, you could do mechanical pupillary dilatation first, as you did here, and remove the membrane, and you could do a radial incision in a more drastic technique. You do a radial incision in the iris and to dilate the pupil as much as you can and do your job. Then after completing, you do only one stitch at the pupillary margin. That's all.
Good. So I took this way of doing the removal of the membrane over the iris, and then doing my new sphincterotomies that I learned from my dear friend and professor, Dr. Ala Zawawi, that is fan of these sphincterotomies. I didn't have Mulligan at that time. I have the iris hooks, so I didn't expect that the hooks will withstand dilatation of the iris. But again, the problem is doing rexes in this situation is very difficult. You have to do it by manually and you have to be sure it's 100% okay, because you depend on this rexes and its integrity to deliver the nucleus and then to deliver the epinucleus. You know the anatomy. And again, the message to the juniors, be sure of the anatomy. Be sure that you are working in the nucleus or the epinucleus or the lens matter. You have to be very cautious on doing your cataract surgery. Be sure that it's completely clear. As you see, the assistant is helping me to remove the iris to visualize the situation, to be sure 100% there are no remnants of the lens matter inside or any part of the nucleus, because in these cases, if you have a part of the nucleus in the anterior chamber, after doing keratoplasty, it's really a mess that you go and remove this particle on a new cornea that definitely will jeopardize the endothelium, which is still the endothelium of the donor. So be careful to clean the lens clearly or the cataract clearly by all your means. And at the end, it was a successful surgery with difficult pupillary membrane and constriction. So again, here the message, dealing with small pupils differ from one school to another, but again, you have a solution. Yeah. So can we move to the next case, or you want to do any, you have any comments? Okay. Yes, Mark.
One advice is do not forget to perform a peripheral iridectomy in this kind of patient, because you can have a seclusion a few weeks after surgery.
This is a very important message for all PKs, penetrating keratoplasty. Please do peripheral iridotomy or iridectomy for these cases. Definitely it decreases the incidence of post-operative glaucoma. And it's a very helpful notice. Thank you, Mark, for this.
Yeah.
So our next case is a day case again. And I know that facing mature cataract or hypermature cataract, dense, injecting viscoelastic again, starting doing the capsular rexes. And as usual, and as you all know, once you have starting the rexes, you find that the rexes is extending in both ways. And while you are going out afraid from extending, you are extending iatrogenically now part of the rexes also. So you have a Mercedes-Benz like rexes or the Argentina flag sign, and out of nowhere, it's hyperinflated. So there is more and more extension. So here is the situation, the Argentina flag sign, the known one. And before talking about how to manage a situation like this, let's see how to avoid a situation like this by Mark. Mark, can you explain for us how to avoid simply the occurrence of the Argentinian flag sign in white and intumescent cataract?
Yes, it's just a small advice, because the risk is very high when you have intumescent cataract with a liquid cortex. And there is always a pressure coming from lens. So first of all, you inject the trypan blue, then the viscoelastic solution, of course. But the small advice is to stick a 33 gauge needle into the lens and to aspirate immediately the liquid cortex. Then you decrease the intraocular pressure. And when the pressure is lower, then you can perform the capsular rexis and finish the cataract surgery. So the advice is to know that you will have a risk of Argentinian flag, lower the pressure into the lens, and then perform your cataract surgery. Then it's easy at the end.
Perfect. So
I have one comment, please, Ahmed.
Fadal.
I agree with this technique, but I prefer to do it from the sideboard. The whole technique from the sideboard, not the main incision. So the eyeball is compromised, is pressurized all over the procedure. you make the aspiration through the sideboard and make capsulorhexis small and in spiral fashion, or sometimes people recommend to do double capsulorhexis techniques, one small and enlarge it after finishing it. Okay, so working from the sideboard is more pressurized and more controllable.
It's another good idea. Yes. Dr. Mohamed Mahdy, also you have your comment about how to prevent Argentina flag. Can we hear?
Actually, what Dr. Marc did is excellent, but my preferred technique is to do just a little puncture while an empty syringe on a cannula, a helium cannula ready, and aspirate as much as I can from the fluid cortical materials, and I recompress the anterior chamber and fill it with viscoelastic, and I start my rhexis either in a spiral manner or a very controlled way as I'm used to.
So again, to send message to the audience.
Aspiration.
When you have, I didn't hear you, I'm sorry for interruption, Dr. Mohamed, ما سمعتكش حقك عليا. The message to the audience, when you suspect Argentina flag, there are certain tips and tricks. Number one, using viscoelastics of the cohesive type, not the dispersive type. Helon, not methylcellulose, because this will flatten the cornea without pressurizing the eye more. This is number one. Number two, if possible, and you're afraid a little bit of the positive vitreous pressure, be careful and try to do it under sedation, better than local or under general anesthesia. This will make the vitreous pressure less. Number three, aspirate from the middle of the anterior capsule with a straight insulin needle, not the bent one, to evacuate and to lessen the pressure inside the bag. Number four, don't fill the anterior chamber with visco, because this will pressurize more the anterior capsule, that makes it more liable for the Argentinian flag. These 4 or 5 tricks are very important to prevent the occurrence of the Argentinian flag. And in spite of this, it may happen even in experienced surgeons. So let's see what happened in the case that we mentioned first. So this is the case now. You are thinking, getting the lens matter, aspirating the lens matter to depressurize the eye, and you are trying to fashion a new rhexis. Now, because you cannot do phaco like this, because the pressures are not equalized all around the capsule. If you're doing phaco with the high pressure and the positive pressure inside the eye, definitely this will extend. So the aim is to convert the straight edges into rounded edges. So very important to have your micro-incisional capsular rhexis forceps. You have to have your vitrectomy scissors, which fashions again the angles and create a capsular rhexis-like situation. And again, once you enter the phaco inside, everything will be clarified. If you have a regular, not regular, but a complete rhexis or a continuous rounded edges, it will appear from the first, from the beginning of the surgery. And here you have to be very slow. All of your work should be in the middle. Don't go to the periphery. You don't have regular edges of the capsule. Protect all the capsule and the rest of the nucleus with the spatula under the phaco tip. The ABCs for slow phaco. Of course, here it is fastened about 4 or 5 times. It should be very slow phaco. Again, before getting out, to prevent the extension of the capsular rhexis, inject again viscoelastic to prevent the extension of the rhexis. Keep the eye all of the time pressurized, because if the pressure goes down suddenly, when you remove the phaco tip, this may enhance extension of the capsular rhexis. Again, going back to the old way of doing the irrigation aspiration with the Simcoe double-way cannula, feeling it is more controllable than the IA without pressure, and of course inserting your 3 pieces IOL. And this is another point which is important to stress on. Don't put the regular 1-piece IOL, the 3 pieces with the haptics inside the bag, and centralize your IOL, and the case can pass smoothly. But if you feel any time that there's a problem, you can shift to extra cap and to put your PMMA IOL and take your sutures. So Any comment from the panelists regarding the case? If you have any other ways to deal with or to be sure 100% that your rexis is intact and you can continue and go on for phaco, or you are going to shift from the start for extra cap. What's your opinion, Mark?
Boris is wanted.
Boris is not here?
No, Boris wants to, I want to ask him to talk.
He asked to talk.
Boris or Mark?
Yeah, Boris
Okay.
asked to talk.
Boris, yes.
Welcome, Boris.
Okay, if you allowed me to talk, so then I think that it is very important to mention that when you're already in that situation, when the capsule is expanded towards the periphery, there are two things to be kept in mind. First, that probably in this case, supracapsular phaco will be more safe when you reposition the nucleus into the anterior chamber, or you try to emulsify it on the plane of the iris rather than in the bag as we usually do it. That helps you to avoid additional stress on the zonule.
Sure.
And the other thing is to be mentioned is that you have to watch carefully on the remnants of the capsule, as it was nicely shown by the Dr. Rohit Om Prakash from India, that if the pieces of the torn capsule are floppy, so that means they are not extending to the periphery. However, when the pieces of the capsule become folded and tight, that is the case you suspect the anterior lip goes to the equator. And then you have to be very careful and maybe stop at that point and then convert to extra cap.
Thank you so much.
I think these are two things to be.
Really two important points. Be sure that your nucleus in the anterior chamber will be safer, and have a look to the edge of the capsule if it is straightforward, flat, or it is turned back. If it is turned back, this means that it is extending to the quadrant. Very nice comments, Boris.
Very nice tip about the flap. Very nice tip.
Yes,
about the flap mobility and this extended.
But all of the time, I was asking why these cases are going well with phaco. I didn't notice that there is any difference, but now, as you said, Boris, if the flap is turned back, this means that it's extending to the equator. You're right. Thank you so much. Any comments? Okay, so let's move to the next case. And we learn from the Argentina flag sign how to deal with it and how to prevent it and what are the tricks of the flap and its level. Dr. Hatem, this is your case. So please, you can go ahead and...
okay, you can start the case, please.
Sure.
This is hard cataract, routine in Egypt, in Upper Egypt, especially in Sohag. Capsular rexis staining in this case. My preferred technique is divide and conquer. As you see here, there is a little bit hole in the center. It looks that I went much deeper than expected. So it may be I ruptured the capsule. After removing 1/2 of the nucleus and emulsifying it, take care at this point. The worst scenario, there is a very big rent in the posterior capsule. Nearly 1/2 of the nucleus is not touched up till now. Very large rent in the patel area with in this condition. What
Dr. Hatem, please, again, there is an important point to stress on in the early part of the case. Yes. So
this is
I want you to explain it again, especially for all of us.
Okay, in the middle.
Can face this.
During the trenching.
Okay.
Yes. After doing the rexis, which was very regular.
And phaco emulsification, the divide and conquer. You will see here, I find it after revision of the video, there is a hole in the center. I noticed it after finishing the case. When revise the video, that's why you must record every case to learn from it. And when complication occur, you must re-evaluate the case again. This is the cause that I made a hole in the posterior capsule in this area. So you can move, Dr. Ahmed.
This is the hole, that's right?
Yes, this is the hole.
So it's very important to revise, as you said, your videos.
Yes.
Nothing happened. I'm doing this case every day. Why this happened? So as you said, you noticed only after revision. That's right.
There is always a mistake. Nothing is bad luck. What we are saying
wasn't in a hurry.
it is
You
bad
have
day
fun.
or bad lucky. No. There is always something wrong from you, from the machine. But if there is something wrong, you must identify it to avoid its occurrence again. The best way to learn is if you're seeing your videos more and more, your own operations.
So now you have this situation.
Shift to the next slide, please, Dr. Ahmed.
Yes, this is the situation.
Yes, very large rent in the posterior capsule. Half of the nucleus is present in place. What will you do if you are in my shoe?
A point again to stress and to agree with the comment that there was a hole in the middle of the nucleus, that the rent is here.
Yeah.
So it started here. So it goes with the opening that we started in the deep phaco, because you were expecting it. It was very hard, or the power was very high.
Yeah.
As you said, there is something in the machine.
It looks that I wanted to make a very deep groove to help the fracture, as it is hard. So it is deeper than needed. Yes.
Yes. So
sometimes it occurs.
Boris, what are you going to do in a situation like this?
I also mentioned that the vacuum setting is 500.
Yes.
So that might be one of the reasons why. By working on the deeper side of the nucleus, you may be aspirating a little bit too much to that. So
vacuum 200s during phaco 2, not the groove. It is opened during phaco 1, where is the vacuum about 100, not more, during phaco 1.
Oh, okay. So because I
this
see
is
now
after removal.
Yeah.
Yes. This is after removing one half.
Okay.
This is my routine parameters is 500 vacuum with this machine, with Infinity machine.
For me, a case like this, I would thinking in conversion, putting viscoelastic, getting the rest of the nucleus out through large incision, thinking what I'm going to do in the rest of the capsule. Am I going to put a PMMA IOL, or because I'm a little bit afraid of doing phaco again in a case like this. Mark, what do you think, Mark? You have
yes. My advice would be to inject triamcinolone into the anterior chamber to see how is the vitreous behind. If this is a liquefied vitreous, there will be a high risk of dropping the lens onto the retina. So if the triamcinolone goes into the vitreous immediately, I will perform extracapsular extraction through a tunnelized scleral incision. And if there is the vitreous body, I will repulse the vitreous body with a viscoelastic solution and try to perform phacoemulsification. So I will try to evaluate the risk of the lens to fall into the vitreous. And if there is many vitreous, most of the time it impedes the lens to fall onto the retina. So I will inject further triamcinolone to evaluate that.
Okay. Boris want to speak. Boris. Okay, Boris.
Yeah, I think it's a good advice from Mark. But to my experience, when I'm dealing with such a hard cataracts with brown, so this is usually patients with the older age, and in these cases, there is always vitreous syneresis, and the vitreous is very much syneretic, so it's very much diluted.
You're right. You're right, Boris. You're right.
Yeah, but I also agree with you that probably in that case, given the big slit in the posterior capsule, I will be planning to convert and to remove these fragments manually.
Okay.
And my preference will be to expand the clear corneal tunnel rather than creating the new one, which is scleral, because in this eye might be soft, and you will be having a lot of difficulties creating the new scleral tunnel incision. So although even given the astigmatic considerations, I will probably go for extension of clear corneal tunnel and then removal of these parts.
Let's see what Hatem did.
Scleral incision is only 5 millimeter.
Okay,
Yes.
next slide, Dr. Mohammed. In this condition, the key is to inject dispersive or never run away, always pressurized anterior chamber. As you see, I'll inject dispersive OVD in this condition. My preferred one is viscoat without financial interest to seal the rent in the posterior capsule.
Hatem, you did not get the phaco tip out. You kept the phaco tip inside.
Yes, I keep it before. Yes, never come.
Yes.
Then evaluate the rupture. It is a very large tear. So I decided here to support the half of the nucleus by moving it to put it in the anterior chamber outside the bag, hoping to place it in the anterior chamber. And as you will see here, I'll insert multi-piece IOL. It is well supported in the anterior chamber. It is safe now. Insert multi-piece IOL in front of the iris, acting as a scaffold IOL. Scaffold IOL will act as artificial posterior capsule, so you can make phacoemulsification in the anterior chamber far away from the vitreous with all particles stabilized. Here, you must reduce your vacuum parameters. I routinely do 500. As you see here, it is 200. Inject viscoat multiple times to protect the endothelium. Act as a slow phacoemulsification with multiple and frequent injection of dispersive OVD. As you will see, then I'll position the multi-piece IOL in the sulcus in front of the capsulorhexis. One haptic, the leading one. Then the trailing one positioned slowly without any flexion, but just dialing and rotation of it. After this part, I'll shift, as you see, IOL now is well centralized. Then I'll go with the cutter to clean any vitreous present and go behind the IOL, making use of the cutter of IA cut and cut IA to aspirate. Here, no cut here, as you see, removing the vitreous. Aspirate without any cutting, aspirate any lens matter. IA cut, here no cutting at all. So cleaning any lens matter present and any cortex. Again, removing the any viscoelastic, any vitreous strands. Hydration while eyeball is stabilized during continuous irrigation without running away. As you see, it is pressurized eyeball. I inject air to take a picture second day. This is second day with air inside in the anterior chamber. You see cornea is excellent, pupil is rounded, everything is okay. It can be managed well. Scaffold is really helpful in this condition. Some people will prefer shifting to extra cap. I find in this condition, scaffold is very effective and working in the safe side.
Really marvelous, great.
Yeah,
yes,
I think it's a great technique that to be shown with maybe one comment. So when you do the IOL scaffold, you have to be very careful not to touch the lens with vibrating ultrasonic needle, because otherwise you will have scratches or very damaged optic. So you have to be quite careful. It's a nice technique. It's a very elegant technique, but don't touch the lens with the needle. Vibrating needle, otherwise you will.
Totally agree with you in this condition. That's why the bottle height is still high, the same height. It's the maximum 110, and always inject dispersive OVD frequent times. Viscoat by name in this condition. Viscoat is the best one to protect both the lens and the cornea at the same time.
Marvelous, great work, Hatem.
Dr. Mohamed Mahdy, you want to give comments, please?
Yes.
Please.
Yeah. I totally agree with the excellent technique that you have used, Dr. Hatem. And I had been faced with two cases like this. One is exactly like your case in a soft cataract, but I noticed I suspected the hole during the phaco. So I kept the parameters as low as possible, and it maintains as it is during the whole phaco procedure. And I was lucky that I inserted the IOL in the bag without any problem. The other case, it happened like what you say you do here, but I did injected dispersive viscoelastic, and I supported the lens as the remaining part of the lens as you did, and I used the cannula of the viscoelastic as a scaffold and I removed the remaining part as you did, but without inserting the lens. Here, I am commenting on something else. Here, you was lucky because in such a case, if you have a fluid vitreous, it will not wait for you. It will go completely posteriorly. In this case, because vitreous is an important.
I disagree. I disagree because this is one half completely is present subincisional away from the tail, and this is if the half in the battle area. I didn't move the nucleus to the battle area except after injecting, acting as pseudo scaffold by dispersive OVD.
You was doing phaco exactly inferiorly at the place where the defect occurs. So if there is any lens material, it could have pushed posteriorly. So the non-fluid vitreous supported your fragments little bit till you found the solution.
Okay. One point.
And maybe one more comment, if you don't mind. So because I just want to make a little bit of history, because the ideologically the IOL scaffold technique come from the sheet glide.
Yes.
And the sheet glide that comes through the main incision, this is a silicone device.
Yes.
That was used to go under the lens nucleus and help to emulsify the lens inside the anterior chamber.
Yeah.
And there is a device which is called perfect capsule, which is also the one that helps you to do the same thing, although you have to insert and to remove it before IOL implantation. So there it's kind of, old idea goes into the early days of phaco, of supporting the nucleus and helping it not to fall down into the vitreous space.
Boris, your comment was just sent from one of the audience, why not to use the sheet glide? So it's another idea, the same brainstorming. But Hatem, we got a lot of congratulations and applauses from the audience of your very nice video. So congratulations for this nice.
Thank you. Thank you, Professor.
So we can move to the next case.
Go ahead. It's excellent, Hatem.
So now we will go to the group of subluxated lenses and how to deal with. This is a 70-year-old patient with pseudo-exfoliation, as you see, and the pupil is not dilatable at all. And I decided to put iris hooks from the start to facilitate the surgery that I thought with just putting the hooks, it will help everything. Of course, you can change the situation of the hooks depending on your preference, depending whether you're left-handed or right-handed surgeons, or this, of course, as you know, are self-sealed incisions, and they don't bother the integrity of the wounds. Then injecting the visco, doing the rexes. Once you put the SATU in the anterior capsule, you see that the whole lens is moving. So the SATU or the needle will not work. So I used the microincisional capsulorhexis forceps, which is more controllable, assisted by the second hand, which is the iris spatula, to support the subluxated, nearly totally subluxated lens. And after completing the rexes hardly, as you see, there are some extensions of the anterior zonules, even anterior zonules to the edge of the capsule. So here I decided to support this lens to put the hooks in the back intentionally in the anterior capsule. And I put one here at 11 o'clock and the other at 7 o'clock to support the capsule and to convert this loose lens into supported one. Definitely it works. The nucleus became more stable, and starting doing my visco, which I prefer to minimize the size of the nucleus, visco dissection, and another incision to have an easy angle for your phaco. So you can even do more incision. If you find the incision, the angle between your phaco tip and your second hand is a little bit shallow or closed angle, you can make it larger angle by changing the side of the second hand, which is, it's very important to have support with your second hand as it protects the capsule which comes inside and outside. Injecting visco again and then turning to the IA. At the end of the day, we finished the case. Phaco emulsification, yes, but the capsule is totally loose, and cleaning the lens matter from behind the bag. As you see, every time we get the lens matter, some of the bag moves more and more, you see that there is nearly 3/4 of bag is loose and subluxated. I removed the hooks and then starting to think, what should I do for the next step? So here we open again the question to the panelists. You have nearly totally subluxated lens. Here is the back, clean, clear. There is no vitreous. What are you going to do? Mark?
Yes, first of all, I would like to say this is the best option to put the hooks to hold the capsulorhexis, so you can perform the cataract phacoemulsification on a centered bag. So it's a very, very good advice. But at the end, the zonula is completely weak. So I will gently remove the entire bag with the forceps and implant fixation to the iris thereafter.
Okay, you have another opinion? Yes, please, Boris. So Mark's opinion is to remove the whole capsule and put Versailles or anterior chamber phakic IOL. What's your opinion?
I think there are several options to be considered, and obviously iris fixated IOL in that case is one of them. The second option is to remove the bag and implant the anterior chamber IOL, which we know in a certain age of the patient will be working quite well. However, my personal preference in all of these cases is try to save the bag if I can. So I will be using modified capsular tensioning that will be fixated to the sclera and try in the bag IOL implantation, which I believe will be possible in that case because we still have the clean bag. It's in place, so it's technically possible to implant the modified TTR into the bag and fixate it to the sclera.
Okay, Dr. Mohamed Mahdy, what's your opinion? Dr. Mahdy, unmute please. Unmute. Mahdy, unmute.
Okay. Do you know that this case was such a kind of subluxation beforehand or not?
No.
No, you find it in intraoperative.
Table, yes.
That's why I agree with you. Did the best thing that you use the capsule hooks to support the iris hooks to support the capsule. Otherwise, you could have used the capsule hooks because it is more gentle. The other thing, I had something else. You did completely remove the lens material with the cortex before inserting any capsule tension ring or Sioni ring. I think, from my opinion, it could have been much easier for you if you inserted before removing this, because during the removal of the cortical material, the capsular bag in the fornices tend to come toward you if the lens material is sticky.
A very good point that you mentioned.
Yes.
This is one thing that I took my decision once I removed my phaco. I felt that this bag wouldn't withstand any maneuvers inside. So it's a very good notice that you noticed that I didn't put anything, because nearly I took my decision, which goes with the school of Marc. Let's see the two solutions. So simply, when I returned the bag back, I found it's very unstable. So I decided simply to remove the whole bag out.
Because it was completely loose, you know.
There is nothing, as if you already in the old days of injection of alpha chemotrypsin in the intracap to get your zone use. So just to be sure that everything's okay and the bag is okay. And then I remove the hooks and continue with the regular Versailles, opening the 6 mm and constricting the pupil, the usual way that most of us know. And it's very simple. I prefer putting it again in the anterior chamber. I'm not a posterior segment surgeon, so I'm a little bit worried of dropping of if the inclinations are not so stable, it may drop back in the vitreous. It could be harmful. So I'm usually putting my the Versailles in the anterior chamber. But let's see what was Boris MAlugen thinking. And this is your case, Boris. So let's see your case. I'm just, before you were talking about it, I know here that you're injecting trimethalone. I'm going to ask you why. And I want to stop here to ask the panelists before you talk about your case, Boris. Here is the case of Boris, that it is nearly half the zonules are dehiscent and there is vitreous in the anterior chamber. So before showing your case, let's listen. Hatem, what's your plan in a case like this?
In a case like this, it is traumatic, Boris?
It is
traumatic, yes.
Would you please?
Yes, it is traumatic cataract.
It is, yes, I think there is capsular fibrosis of the anterior capsule, zonular dialysis, vitreous in the anterior chamber. In this condition, I will start injecting OVD, triamcinolone like this. I don't prefer triamcinolone every case. I can do vitrectomy without it, removing the vitreous from this condition. Then I will try to make capsulorhexis, alternating between capsulorhexis forceps and sometimes scissor if there is fibrosis, to make scissor to remove, to cut and have a continuous edge capsulorhexis. If I have a continuous edge capsulorhexis, I will support the capsulorhexis using capsular hooks by 2 capsular hooks in the area of subzonular dialysis. Then I can do my fecal emulsification, but sure, I will insert, I make scleral fixation. I prefer Sayoni ring with 9O-proline 0 scleral fixation through Hoffman pocket.
Let's see what Boris did. Boris, please go ahead.
Okay, if you switch on the video, so then we may continue. So it is not always necessary to do vitrectomy, because you can actually reposition the vitreous. First you stain it and then reposition it with viscoelastic. So sometimes it's good to stain and reposition the vitreous, not to do vitrectomy from the very beginning. And this is capsulorhexis, which is going around the central plaque. And I'm using the modified capsular tension ring, which is the Mulligan modified Sioni capsular tension ring. You see that there is only one eyelet, and it's located at the end of the device. And what is important, I'm injecting the device towards the area of the zonule of defect, because I want the residual zonule to stay healthy and to support the capsular bag. As shown here, because of this modification, when we move the fixation element to the very tip of the device, so it's completely injectable, and we can actually easily inject it inside the capsular bag. So there are 2 options. First, one that I used here is to implant CTR at the very beginning of the case, because the zonular defect is very big. So I decided to suture the CTR first, and then to remove the content and the lens out of the bag. Although by doing that, we have to keep in mind that by injecting CTR at the very beginning of the case, you're actually compressing the cortical material towards the equator of the capsular bag. And then you will have some difficulties in irrigation aspiration phase of that procedure. Also, you have to be quite careful by irrigating, aspirating. I always use bimanual in this case. And now, actually, I'm not aspirating the cortex. I was aspirating a little bit of vitreous, which is now just being stained. And again, I see the vitreous strands. So in spite of the fact that your bag is sutured to the sclera, there is still a massive zonular defect, and the vitreous can come out through this defect. So you have to keep that in mind. And by staining the vitreous, again, I was not planning to do vitrectomy at that point. So you can reposition it. And then as soon as the lens is in the capsular bag, bimanual vitrectomy is being done. So there are several, I believe, good points from that video.
Yes, many good points. I have 2 comments or 2 inquiries. The first, how would you dare to rotate this nucleus or the lens with the CTR inside, unless you are sure 100% that the other part of the zonules are very strong? So if it is a pseudo-exfoliation or with this hard cataract, can you rotate again the CTR inside the bag like this? This is the first question. What's your opinion, Boris?
You know, you're completely right. So the rotation is a bit tricky when the the residual zonules are very loose. However, in the case of very loose zonules, you can actually use capsular hooks and you can support the capsular bag. And with that support, with that additional support to the zonules, rotation of the ring is easier and more stable, because while rotating the ring, what you want to avoid is that you don't want to avoid unzipping on the healthy zonules, which may happen in that case. So I think it's a good point. So consider using capsular hooks.
It's a very good message here. So you have to know what is the cause of this subluxation. As Hatem asked, is it traumatic? Yes. So yes, you have to think, if it is traumatic, you can even rotate the CTR inside the bag. And the second comment is turning back the vitreous. It is not the basics that we all of the time we learn that once vitreous is out, do vitrectomy, because this will affect the anterior vitreous face to induce traction to the periphery. The patient may have peripheral retinal breaks. So I don't know whether in your, why not simply to do the vitrectomy instead of turning back of part of the vitreous that you are not sure that everything is okay. What's your opinion? Do you agree with me that to make the message to the young generation, just vitrectomy is the rule, or you have experience on turning back the vitreous if it is out? What's your opinion?
There are two types of vitrectomy that can be considered in that case. First is the regular wet vitrectomy, when we irrigate through the side port and introduce the vitrectomy probe through the other port. What is the negative side of this type of vitrectomy is that you're actually hydrating the vitreous, and you are promoting more vitreous coming out. There is another type of vitrectomy that can be done in that case, which is called dry vitrectomy. And dry vitrectomy is done under viscoelastic. It's done without irrigating the anterior chamber.
Yes.
And this dry vitrectomy, to my mind, is more preferable.
Right.
However, by saying that, I must also emphasize the fact that when you are using dispersive OVD, 25 gauge vitrectomy probe is too small and the OVD is too viscous to do effective dry vitrectomy. So you either use the regular 21 gauge instrument or 23 gauge instrument in order to get effective vitrectomy in these cases.
Perfect. So,
and the final comment is whether it is safe to reposition the vitreous and not to cut it. So it depends on the amount of the vitreous coming out. If it's a couple of single strands, it's quite easy to do that. But if it's a massive amount of vitreous coming into the anterior chamber, you obviously need to cut all these strands away.
Perfect. Hatem, thank you, Boris, for these illustrations.
Two questions, Boris. Please, first one, you inserted the modified CTR before hydrodissection without any viscodissection. How you be sure that it is going to support endophoresis, not within the lens matter itself?
So from my experience, I do like to inject the CTR right before hydrodissection, because what happens with hydrodissection, when you inject the liquid inside the capsule, so you lose your visualization of the anterior edge of the capsule.
Yes.
So that you're not sure that you can inject the ring right inside. So you either do it right before, right after capsulorhexis, before hydrodissection, or at the very end of the procedure when the whole content of the lens is evacuated from the capsular bag. So my current preference is to do it at the end of the procedure. So I think it's more safe with the hooks that we have now. With the capsular hooks, it's much better. However, this video was done when the capsular hooks were not available, and that was my technique at the very beginning of that route of learning of the technique.
Okay.
So
The
the
second
message
question.
here. So yes, Hatem, please go ahead.
Okay, you can. If you have no time, you can continue.
No.
I want to ask why you tightened the suture to the sclera from the start. You find it at the end there is vitreous prolapse again. I think if you make it a little bit loose and tighten it after removing fecal emulsification, as we all do in cases, any case with Hoffman buckets and scleral fixation, we tighten at the end to allow centralization, ensure centralization of the IOL at the back. I find you tighten it at the start, at first.
I think you probably mentioned that, but I was using so-called zigzag suturing. And zigzag suturing is was proposed by German surgeon Peter Schurman. When you pass your needle parallel to the limbus, usually 4 or 5 times, and you keep the end of the suture, and you cannot even make it a knot at the end because it's quite secure.
Yeah.
So with zigzag suture, you can tighten the suture anytime you want. So you make it loose or more tight at any time point of the surgery. So it's not a big issue, as opposed to the permanent suture when you tie it and then you cannot adjust it anymore.
Yes.
Sure.
Okay.
So
Thank you,
the
Boris.
message here is there is a dry vitrectomy, wet vitrectomy. The wet vitrectomy will induce more hydration and more vitreous to be lost. The dry vitrectomy is better. This is the short message. Dr. Mahdy, do you have any comment?
Yeah, I don't have much to add to this because all what is needed is done, but only for the nuclear division, I could prefer to do nuclear in situ practice without rotating the lens at all to avoid disinserting any part of the zonules anymore. Just to do in situ nuclear disassembly in this case.
Okay, let's move to the next case. Again, it is one of Boris' cases. So here we are going to another point, which is the iris repair. So Boris, please go ahead and tell us about this very hard fibrotic anterior capsule. Unmute, Boris. Unmute.
This is again traumatic cataract with the plug and the central plug. And again, I will be using the modified scleral fixated CTR. And again, as shown here, which is very important, I think, to any CTR. So I inject CTR towards the direction of the zonular defect, which is, don't matter, you use modified or regular CTR, always inject the CTR towards the area of the zonular defect, which helps you to keep the rest of the zonules more healthy. As soon as the injector is used and the eyelet of the CTR is released, and then I'm again rotating the CTR and then going through the sclera, and this is actually a repositioning of the fixation element on top of the anterior capsule. There are many ways to repair the zonular dialysis, and the many ways to repair the iridodialysis. This is one of them, by suturing and making a knot from inside of the eye, and there are sewing machine and there are other techniques, so far and so forth. And as shown here, but the only one thing that is missed in that video, because always in these cases when you have such a traumatic zonular dialysis and such as you always have traumatic mydriasis. So you need, at the end, you need to suture this pupil and to make it constricted, because otherwise it will be dilated and it will never constrict.
Very nice case, Dr. Boris.
Very nice case, and the iris repair. So here we are moving to another entity, which is the group of the iris repair. So let's see Dr. Mahdy case. And as you see here, Dr. Mohamed Mahdy, please tell us the problems that you are, sorry.
Back. Yeah, just go ahead.
And then pause the problems.
Yeah, okay. This case was a traumatic iris dialysis with lens subluxation, traumatic cataract, and anterior vitreous prolapse in addition to secondary glaucoma. The decision had been made pre-operatively that I will not deal with the glaucoma at this stage. I will try to remove the vitreous first, and I will repair the iris, and I will try to remove the lens. I'm not sure exactly what is the status of the posterior capsule is. And I went to this case without managing the glaucoma at this stage. I started with staining the vitreous and staining the anterior capsule with both triamcinolone and trypan blue after repairing this iris with the through the scleral flaps that I did without. Of course, I am not used to the Hoffman bucket yet. And I repaired the iris, then I removed the vitreous. Then I started doing the rhexis after this. Okay. Here I'm staining the capsule, then I'm staining the vitreous. I'm removing the vitreous anterior vitrectomy. Then I will do rhexis with the needle. But at certain stage where there's a fibrotic capsule at this area, it's not going well, I will use the scissor. Is a mix of capsulorhexis forceps, needle, and at this stage it is fibrotic and cooked with the inflammation. I will cut it with the scissor. Then I will continue completing the rhexis with the rhexis forceps. Then I am not inserting the then I'm inserting the capsule hook that I was ready with it now to support the dialyzed part of the capsule. Then I remove the lens material, which was very hard to separate from the cortex with hydro dissection. Once I finished completing this lens material, I inserted the CTR and the IOL in place as usual. The decision not to insert the capsule tension ring before this stage is that I don't know exactly what is the status of the posterior capsule in such a traumatic case. Do you agree is that I delayed the capsule tension ring insertion till the last stage? I see Dr. Boris is injecting the capsule even in the traumatic case from the start. That's the point that I was afraid to do. It's okay.
Nice, very nice, Mohamed. Very well managed. The audience even agree that you don't need to deal with the glaucoma at this stage.
And there was no glaucoma later on,
yes,
sure.
Yes. And did you do glaucoma surgery at the end of the later on, or you didn't?
No. It was a secondary glaucoma to the presence of the vitreous. Once you remove the vitreous, it's all done.
It's all.
Without
the next point that you also mentioned is the Halon GV.
Yeah,
I think
for sure.
you have tell us about more experience of the Halon GV. Should we have it in our ORs as a third weapon or as a third hand?
You should have it in this case, sure.
Yes, and you have it. It's easy to be available Halon GV to get it from the market now, or it's not available.
There was a Halon from the German company by Alhamd company. You know, it is not the original one, but it is equivalent to it. It was exactly very nice one. And
okay, so for the sake of time, because you have more nice cases, so let's move to the.
I want to comment on something.
Yes,
No.
sorry, please.
No.
Please
I want to comment. It is very nice management. Time of insertion of capsule tension ring, in my opinion, is as late and safe as possible. In this condition, it was safe to implant it at the end. In Boris' case, there is severe cases of dialysis from the start. It is better to insert it at the start. So it is a different according to the condition, but yes, you must insert as late and safe as possible.
Sure, this is a very important point to stress on, when to insert your CTR.
Yeah.
Okay, moving to the next case. Mark, can you tell us about your case of iris repair and how to manage cataract and iris defect, again, traumatic cataract? Mark? Yes.
Okay, this is also a post-traumatic cataract. You can see the scar at the top of the cornea. So we start surgery with triple and triamcinolone, and I agree with Boris. You see the vitreous body and you just repulse with viscoelastic solution. You don't need to perform a vitrectomy. Most of the time this will hold the capsular bag. So don't remove the vitreous body at any time. You can just push the vitreous body. So we hold the capsular bag, and this is a weak zonula, but only on a quarter of the zonula because it was a penetrating wound and not a contusion. So I don't advise to implant anytime a CTR. This is a 3-piece IOL, and in many cases, you don't need to implant a CTR. Before, I used to implant many CTR in all zonular weakness, but not now. And you just have a weakness of the zonula in this part. And the intraocular lens is well centered, and it's not always necessary to put the intraocular, the CTR.
I don't know, Mark we may have a different opinion. I don't know. I don't dare to leave the patient with this dehiscence, whether either to rotate the IOL.
Rotate the IOL.
Support. Let's see the next what you did later on. Yes, please go ahead, Mark.
In fact, I try to rotate the intraocular lens, but there is a fibrosis, and you can see that in this case, the intraocular lens couldn't be stable in another position than this one. And you'll see that what is important is to have a centered intraocular lens. So we have several propositions to repair the iris defect, either by suturing, or we can also implant a CTR with opaque segment. In this particular case, I decided to repair using the Sipser's note. So you use a Leicester hook at any time. You perform the suture outside the anterior chamber, and you slit the knot inside the anterior chamber. But you see that in this situation, you will not be able to repair all the defect because it's impossible to suture all the iris. So in this situation, but there are many other propositions, I perform an intrastromal pocket using a spatula, and you see the insertion of the dark ink to tattoo the cornea just in front of the defect. And you can use several dye to repair the color of the iris. So first of all, I use the dark to block the light, and then you can add another color. So this is the brown dye into the stroma, and you can mix the dark and the brown until you obtain the good color of the iris. So this is what we obtain at the end of the surgery.
Fantastic.
So you are mixing colors and doing different.
Yeah, now we got something.
Yes. You mix the color into the stroma.
Yeah.
So, and at the end you remove
Perfect. Very nice. So again, everybody's question: is it toxic to the cornea or not? These dyes.
No.
Is it safe to put the Indian ink, and what's the nature of the second brown color, Maurine?
Yeah.
The brown color. It's a dye. It's a color designed for dermal tattoo, and it's also for corneal tattoo. This color was designed for corneal tattoo.
Nice, very nice, really very nice. And again, your last case, Mark.
This is the same type of patient, but in this case, I decided not to perform the tattoo, so you can use a CTR with an opaque segment to block the light in the area of the iris defect. So you repair the iris in front of the segment, so you don't need to perform a corneal tattoo in this case. So
really, I'm fan of Marc's maneuver because it has many solutions for many problems. It's very malleable, very innovative. Thank you, Marc, for these nice presentations of the different iris repair that you summarized in less than 5 minutes, 3 different types of iris repair and iris defects. Can I hear any comments from, thank you so much. Can I hear any comments from the panelists?
The only thing that here, if you did your suture a little bit peripheral, you could have a wider pupil, but more central.
Here
okay.
You know, this is the only thing. But all the others, I agree with you. It is an innovative solution and smart ideas for sure.
I want one comment. Excellent, Marc, for this very nice, very excellent management. But why you don't make the tattoo in a second session? Is it safer to make it is in a second session to make after a closed system, no chance for leakage of dye into the anterior chamber? It may be safer, or you find it is effective and safer one session?
Yeah, I couldn't well understand. You mean
tattooing? I know tattooing big egg and a second session, not the same operation. 2-step surgery.
Yes, of course, yes. No, it's a good advice to do it in two surgeries, of course. Yes. There is a risk to perform an extraocular surgery and intraocular surgery in the same time. Yes. I agree with you. And we don't want the dye, the color to go into the anterior chamber. So yes. It's a little more tricky, it's a little more risky to perform in the same surgery. Most of the time we do it in 2 surgeries, but in this case, I don't remember why I did it in 1 surgery.
Okay, Marc, I agree with you. Yes, I agree with you for your techniques of iris repair. It's very nice, and you are adapted with the modified sepsil knot again. And our junior staff again are learning the modified sepsil knot, and they are agreeing with you. But I have small comment that Ammar Agrawal in 2017 had modified this sepsil knot into the 4-pass, single pass 4-throw knots. And I tried it, and just to show it, it's another way of iris repair. Again, it's very simple. Just let the needle pass from one side and passing through the iris, whether to catch it from the other side with an end gripping forceps or with a capsulorhexis forceps. And as you did, passing the needle through the iris, and simply when you get it out, having the loop from one side, so you have 3 threads, the edge and loop, and just simply pass the free thread through the loop 4 times, and that's it. So it's worth to try. It's easy illustrated, whether here, and I'm stressing again to all our audience that all these videos will be available on a link on the YouTube, as it is a recorded webinar, and even the ways of suturing the iris, just passing 4 times the needle through the loop, and that's it, without returning back, without the little bit more difficult, the modified sepsil. It's another way, just to be mentioned, but the way that you are accustomed to adapt is an easy way to do, as long as you are repairing the iris, and again, pulling the iris, and it will work just with this single pass 4-throw knot.
Thank you.
And you can
thank you, Ahmed. I've tried it since our last webinar because you gave me the idea of using this technique. So I saw the video and then I tried it, and of course it's a good idea. It's a simple solution to use that when we want to repair the iris. I will not use if I need to fix an intraocular lens to the iris, because I want to block the knot. But I think to repair the iris, it's a very good solution, and thank you for giving me this idea.
Can you do it in a phakic one?
Yes. Yes.
Can you do it in a phakic patient?
In phakic, yes,
Yeah.
yes, you can do it in phakic patients also.
Yeah, but you should be cautious with it. Yes.
We're very cautious.
Yeah, we can do it in a phakic patient, but of course it's more difficult, and you
Yeah,
have
yeah,
to.
but,
Yes.
Okay,
I agree,
so,
Dr. Ahmed, that single pass for through make iris surgery much easier, really.
yeah.
thank you so much. So moving to the pre-last case, I know that we took a long time, but I'm happy because the number of audience didn't fall down. That's why we just have maybe
Only 12%.
Yes, 1 or 2 cases to be left. So Dr. Hatem, can you tell us about your case of...
This is a case of routine phaco, mid-dilated pupil, rhexis through microcapsulexis forceps. As usual, hard cases. It is our hard cases. But while you are doing your maneuvers, as you will see, pupil is going narrower and narrower every time. I made the grooves, but I couldn't fracture the nucleus. I am a fan of divide and conquer technique up till now. So pupil is going narrower, slower, and you will find it very hard nucleus, didn't divide it, and narrow pupil like this. So what will you do? Intraoperative narrowing of the pupil after doing rhexis without fractioning of the nucleus. Next slide, please. Yes, this is the condition.
Yeah. So, of course, after this webinar, we know that we can put the Mulligan ring, we can put the iris hooks, and this will solve the problem. As we said, you have to have your second weapon ready in the OR. So, go to the more problematic point before Boris is going to talk about his ring. So, what did you do, Hatem?
I tried to inject intracameral Medriatic by a special type of cannula. This is used for staining. It is directed posterior toward the iris to inject the Medriatic towards the iris, but many times, unfortunately, the pupil not dilate. So I shifted to use my Mulligan ring. As you all know, I am a fan of my Mulligan ring. Thanks, Boris, for your ring. It is really helpful, but injecting it after doing capsulorhexis is a little bit tricky. As you will see, I injected it, routine injection. I don't know why the net is slow a little bit. So after position it, in this case, you must ensure that it is well centralized and not catching the capsule. In this condition, you will see it is catching the capsule. One of the eyelids, this one, the leading one, is catching the capsule, the anterior capsule. Here's the decision whether to continue phaco in this condition. So spatula not moving, it is catching the capsule sure in this condition. Pupil dilated, but capsule is catching. Here, the decision of me is I was afraid if I make phacoemulsification in this condition, maybe back displaced. So I decided to disengage the Mulligan ring and reinsert it to the iris, disengage it from the capsule and the iris, and reinsert it to catch the iris only after injection of staining to trying to see the capsule. Now, ensuring it is not including the capsule. I know sometimes we use the Mulligan ring even to catch the capsule when there is a little bit dialysis, but it is better to be catched in 2 sides, not one side.
Here is the trick of this video.
Yes.
Yes, so the Mulligan is in the capsule. And we have, in the rehearsal, honestly speaking to the audience, we had different opinions. So you, Dr. Hatem, enlarged the Mulligan ring and continue your surgery. So can we, very nice maneuver, of course, and then you remove the ring. Can we ask Boris, do you agree with Hatem, or I was asking with Dr. Mohamed Mahdy to leave it entangled in the anterior capsule and continue your phaco till the end? So can we hear from Boris his comment?
From the inventor.
From the inventor himself.
You know, I think it was, first of all, it was a good idea to implant the ring because actually you do have a chance to catch the capsulorhexis edge with any device you are going to implant. For instance, you try to implant iris hooks, and also you have a chance to catch the iris together with the capsulorhexis stage. So there is a risk of any device to be implanted after the capsulorhexis. So my personal advice in this case is first try to inject cohesive viscoelastic behind the iris to lift it a little bit above the plane of the capsulorhexis, because in that case you decrease the chance of catching both the iris and the edge of the capsule. The second maneuver I do in these cases is I call it the picture frame maneuver, because when you take the instrument and you move the ring left and right, up and down, and when you do that, the pupil expansion ring can easily move on the anterior chamber to any direction. However, if it's catching the capsule, so the movement of that ring is restricted in that meridian. So that will, because sometimes visualization is poor and you cannot really see the capsule. So then a restriction of the ring maneuver may give you the idea that you catch the capsule. And finally, I absolutely agree with this concept of Hatem to disengage the ring and then engaging it once again backward in order to release the capsulorhexis stage. So there is still a chance to hook and to catch the capsule, but you can minimize it with a certain type of surgical techniques.
Perfect. Thank you so much, Mark. Dr. Mahdy, do you have any comment?
Yeah, I don't have nothing to add now. It's clear.
Okay, thank you, Boris. So before moving to the last case and congratulating all the panelists for this great work, going back to Marc Maurine with his nice tattooing way, there are a lot of questions from the audience for you, Marc, and they're asking about the dyes and if there is any publication that you can send them. So if you have any publication about this, because many people are interested in tattooing and they want to know more. And there's a question that I wanted to ask you and I forgot, and one of the audience remind me, is that staining the anterior capsule with trypan blue under saline, without air and without visco. And I don't know, once I faced that on staining a patient with the mature cataract, that the trypan blue stained the endothelium. And it was so difficult to do the phaco through the visualization of the opaque endothelium or stained endothelium. So what's your opinion? Is it your routine, Marc, to stain the anterior capsule with the trypan blue without air and without viscoelastic?
Yes, yes. First of all, I don't inject air before injecting the trypan blue. I was doing that several years before, at the beginning of the surgery, when Gerrit Meles published that for the first time. But now you don't have to inject air before. You have to know this is a vital dye. The trypan blue doesn't stain on a healthy endothelium. If you never stain the healthy endothelium with trypan blue. You just have a coloration if it's a pathologic endothelium. This is the dye that we used in the corneal bank. We color the endothelium with the trypan blue, and if there is only living cells, you don't have any fixation of the trypan blue. The trypan blue goes into the nucleus of the endothelial cells and goes immediately out if the endothelial cells is living cells. So you don't have risk to color the cornea.
It's not toxic for the,
I agree with
the healthy endothelium.
I agree.
Okay, perfect. So our last case, because we just have 5 minutes, is now approaching to 2 hours, and still we have 260 participants with us. So to finish, Dr. Hatem, with your last case, please go ahead.
Okay, start the video, please. This is a hard case, 75 years old with hard, totally opaque brown cataract with low endothelial cell count. As you will see, endothelial cell density 1,300 and low endothelial cell count in hard old age. What will you do? here. There is, I think there is a ability here to do manual small incision, to do extra cap, to do phacoemulsification. What are the precautions? What is the preferred technique of phacoemulsification in this condition?
For me, I will go for phacoemulsification and dealing with it as a compromised cornea. So we have to protect the cornea all of the time using the soft shell technique of Archinov from the start, having small air bubble in the back of the cornea through the viscoat or the visco cohesive OVD. Keeping this air bubble on the back of the cornea all of the time means that the ultrasonic power will not go to the back of the cornea, will not endanger the endothelium, using as much as we can low phaco powers, low phaco parameters, in order not to induce more energy with the minimum energy of 40 or 30 or whatever, even in hard cases, depending more on the vacuum than on the power. And these precautions trying to protect the endothelium. Of course, I have to explain to the patient that we have the choice of doing combined DMEC with phaco, but your case can pass without DMEC. So we have to give it the chance of doing phacoemulsification, but you have to know if there is a corneal decompensation till 3 months after the surgery, we may do DMEC after that. So patient counseling, taking care of all the parameters of the cornea and go for phacoemulsification. I don't know if
Boris.
Yes, Boris. And
Okay.
then Mohamed.
I think there are one more thing to be mentioned. So in spite of the fact that in this patient the endothelial cell count is low, it is 1086 cells, but the central corneal thickness is 498,
Yes,
which is not very thick.
Yes.
So meaning that because we can judge the function of the corneal endothelium by the number of the cells,
sure,
and by the function of the cells. And the function of the cells decreases when the corneal thickness is increasing. So there is a recommendation from the several publications considering the threshold of using the simultaneous procedures such as cataract extraction and endothelial keratoplasty when the corneal thickness is over 630 microns.
Yes.
So in that case, the threshold is not reached.
Right.
So it is absolutely indicated to go on with the cataract extraction, informing the patient that it should be the compensation because of the endothelial cell count. And what I will personally advise in that case is just to make the second measurement of endothelial cells, because we know that endothelial cell count is not very reliable and repeatable. So sometimes when you focus on the different zone of the cornea, you may have absolutely different cell count. So consider not only the number of the cells, but the thickness of the cornea, which is the function of the endothelial cell viability.
Which technique of phaco you prefer, Boris? Divide and conquer, vertical chop, horizontal chop, or what?
I will be definitely using phaco chop in this case, and my preference is the combination of horizontal and vertical chop. And obviously, dispersive OVD should be used in a very massive amount.
Boris, you stressed on a very important point is what is the cutoff number for the pachymetry to do combined cataract DMEC and cataract alone. And this cutoff number was since more than 5 or 6 years was only 600 and then raised to 610. And now, as you said, it is 630. So 630 thickness of the cornea means that you can do up to 630. You can do just only phaco without the DMEC. And another point that Dr. Mahdy
this is the recommendation from the American Academy of Ophthalmology. So this is the threshold.
Dr. Mahdy also has a very nice comment on the quality of the cells.
Yes,
so
that's what I want to add. If you look to the graphs that Hatem is displaying, you see how compact is the endothelial cells and how homogeneous are they. The homogeneity.
Yes, I agree with you. Although there is a small number of cells, but hexagonality is high and coefficient variation is small. Yes.
Which could explain why the corneal thickness is not increased. But for this case specifically, I will not go for phaco. I will take the best chance. I would go for the soft shell and do manual small incision in this case.
And you don't go for Sykes for small incision?
Well, yeah, for sure. For sure, because this one is not only, it is hard cataract and it might be brown, it might be leathery. I don't know exactly what I might have to face in this case.
So you do Sykes, Dr. Mahdy?
Yeah, for sure.
Okay.
I don't like Sykes.
Dr. Marc?
Let's see.
I just have one comment. I just have one comment because what Boris said is very, very interesting. The number of cells is not reliable when you have endothelial cell count. You have to see there that you have count only 48 cells. And you have the measurement of the cell density only from 48 cells. So when we repeat the examination, sometimes—
This is the maximum number of cells I got after many times of repeating it myself. I repeat.
48
yes.
is not bad. 48 is not bad at all.
But it is more reliable when it is above 100. I know. When it is above 100, it is more reliable.
Yes, of course.
But
of
sometimes,
course, but every time you have this kind of number of cells, it's not. It's like each examination. We never count 100 cells. It's sometimes too difficult that, but it's difficult to say we have such a precise count when we are able to count only 50 cells. That's so. If we repeat the examination, sometimes we have a difference of 100 cells. So I think that 1,200 is not so bad, and we can perform cataract surgery.
Okay, let's see what Hatem did.
That's why I did phacoemulsification in this condition after patient counseling. Sure, routine capsulorhexis. My technique is a little bit different. I always recommend that you do what you are accustomed to do. I am fan of divide and conquer. Here, soft shell technique, sure, injection of OVD many times. I remove the core of the nucleus, the most harder part while it is in the bag. I make a very big crater in the center and grooves, then divide the nucleus. As you see, sometimes one half is trying, or quadrant trying to come to the anterior chamber. I push it posterior to do phacoemulsification in the bag all the time under umbrella of viscoat by name, soft shell technique, using viscoat dispersive to protect the endothelium. As you see here, you can do phacoemulsification and you can finish the case, although it is hard and take a lot of ultrasound, EFX about 160, most of it during phaco 1 in the bag, far away from the cornea with low parameters under viscoat. The quadrants which you remove will take small amount of ultrasound and many times injection of dispersive OVD with endothelial protection. You can finish the case, as you will see here, removing the whole nucleus. Everything is okay, but the internet is a little bit slow.
Going well.
Implanting the IOL in the bag, whatever the type of the IOL, no relation between single piece, multi-piece, no problem in this condition. The key is to evaluate the cornea the second day. What will you see? Removing the cortex, removing OVD, cleaning all OVD to avoid any IOP spikes, hydration of the wounds, and you will see the patient come. 1 week post-operative, the cornea is very clear, as you will see here. Cornea is clear, pupil is round, reactive, very nice. And this is pre and post, and you will see the specular microscopy. 2 months post-operative, I made the specular microscopy. You will see it is the same thickness, although the count is reduced about 300, less than 300 cells. Hexagonality is reduced, number of cells still low, but it is well functioning. Here, although the endothelial cell count is low, but it is well functioning, hexagonality is good, and the corneal thickness is the same post-operative with a clear cornea. So you can finish it. Even this case, I did divide and conquer. Many people say vertical chop is better, but in my hands, I do divide and conquer well. But under endothelial protection, with making use of the benefit parameters, ellipse here, torsional, some machines, low vacuum. You make use of the machine as you are doing well with it in your experience, in your hands.
Perfect, Hatem. Hatem, what's the name of the chopper that you used?
In this condition, and I use Neuhan chopper.
The Neuhan chopper.
Yes.
Okay, this is a question from the audience. So, thank you, Hatem, for this nice illustrative point. In spite of having a lot of debate about the cell count, the corneal comorbidity, that it may need another webinar of fake emulsification and weak cornea, and this may be the idea of the next webinar again as a panel, I think. So it's now 2 hours. At the end, to wrap up, we got a lot of messages. I really thank everyone that I learned from all the videos of you. There are many tricks that we have learned together. Thank you so much for all of you. We got a lot of messages how to deal with the subluxated lenses, with the iris repair, with the weak corneas, with the last-minute complications, the IOLs, the rent of the procedure. I think it's a nice and a very invaluable webinar. Thank you again, Boris from Moscow. Thank you, Marc Maurine from France. Thank you, my dear friends and colleagues, Dr. Hatem and Dr. Mohamed. And thank for all the audience for staying with us till the end of the webinar. And the link will be available on the R&M Solution website on Facebook. And I would like to have a very good night for all of you, and stay home, stay safe in spite of the unlock of the country. Thank you so much.
Thank you very much.
Thank you, Dr. Ahmed. Thank you, Boris.
Thank you.
Thank you, Mark.
Thank you
Thank
very
you,
much.
Thank you for painting,
Mark.
Mark.
Thank you so
Bye-bye.
much.
Thank
Bye-bye.
you.
It's a pleasure.
Bye-bye. See you.
Bye.
Yeah. Bye.
See you in walk, Boris.
Yes.